Hi everybody, we're going to talk about cardiopulmonary imaging. Mostly we'll be talking about chest x-ray. We'll touch a little bit on CAT scan. So let's look forward to what we'll be covering today in your objectives. We'll be identifying the normal pulmonary structures of a chest film, identifying the heart, vascular markings of course, identifying bony structures of the chest, comparing normal structures versus pathological structures, interpreting abnormal and normal chest films, looking at pneumonia atelectasis among many other pathologies and how you would tell the difference on your chest x-ray. Also looking at why you would pick something. So when do you need a lateral film, for example? What's a PA versus an AP? How would you order what you need based on what's in front of you? We'll look at localizing some abnormal findings today, including cardiomegaly, pneumonia, adenopathy, pleural effusion, bony lesions, COPD, pneumothorax, and tuberculosis. We'll briefly touch on CAT scan as well. So I want you, just before we start talking about x-ray, let's talk about imaging and what is x-ray, regardless of chest x-ray. Remember, x-ray, it's all about the density. X-ray is all about density. That's how it's making the picture. It's really important to understand that when you do determine or you try to decide what should I order today, you need to know why you're doing it, how you're doing it, and how the picture's made. So here, I like this picture because on here we show the fact that tissue depth is one thing that affects density. So here, very skinny or thin tissue can show darker on the film. Remember that true black on a film is nothing. So air, what color is air on a film? Well, it's black. It's black. It doesn't show up at all. The thicker the tissue, the more dense it usually appears. And sometimes the actual makeup of the tissue can make it more dense as well, depending on what we're looking at. So those are the two things that are factors into the density, but I don't want the fact that it says atomic weight on the side of this picture here, I don't want that to make you think differently. It's a density thing with x-ray. And x-ray is CAT scan as well as x-ray. They both use x-ray technology. Don't confuse that with, for example, MRI. MRI is using atomic differences, not weight or density, atomic differences in order to form a picture. So that's looking at differences in the makeup of the actual tissue, meaning that if I have two structures of the exact same density next to each other on an X-ray or a CAT scan, because it's using X-ray, they look the same. I can't tell the difference, but MRI can differentiate those two based on the fact that they are different in their molecular structure and makeup. So let's go forward. Remember, as we talk x-ray, we're talking density. So what can we see with a chest x-ray? Well, let's start simple and then we'll go a little further, but we can see a lot with a chest x-ray. And it's not just heart and lungs, and it's not just lungs. I think sometimes people think that, just lungs. No, not just lungs, a lot of stuff. We can see our lungs, and to go a little further in that, we can actually see different lobes of our lungs sometimes once pathology arises. So we need to remember as we do our chest film the fact that I have 3 right lobes and I have 2 left lobes of my lung. You won't see the lobes on a normal chest film, but sometimes if there's pathology, for example, maybe there's a pneumonia only in this lobe, then it becomes very defined and you can locate where it is. I can see my heart. I can see some valvular structure only if they're calcified significantly or if it's a mechanical heart valve. Of course, you'll see that as well. You'll see pacers, other things. In a normal heart, however, if there's no pathology, you won't see the inside of the heart at all, so you won't see those valves. You can identify the aorta and the arch, right, as well. So to go a little further, looking at a regular film here, what are some things we can see as well? We can see the trachea in most films. You see, air, remember, what color is air? Air is black because it doesn't exist. There is no density as far as the X-ray machine is concerned. So therefore, the extra air sitting in the inside of my trachea shows up as this darkening of this area. So I see there's the trachea, and if I'm very careful, and you guys look really carefully, you can look right here, there's more of that darker area. That's the left bronchus. This is the right bronchus, okay? Left and right bronchus. So when we talk about placement of an endotracheal tube, for example, which you can see, the tube may come to here. That's where it's supposed to be. If the tube's here, then it's right main stem. So you can actually see the bronchus. That's important. Again, as we mentioned, we can see the heart, okay? Left side of the heart, right side of the heart, right atrium here, right ventricle here. I can see the aorta, the aortic knob. I can check my mediastinum here. I can check all of the surrounding structures, correct? Whether it be bony structures, which we'll talk about as we talk about how to interpret an X-ray. I can see the diaphragm. I can see the gastric bubble in the stomach very often. I can look at the whole lung parenchyma. So there's a lot of things I can look at. So we're going to talk about this stepwise approach and why it's so important. Now, what about a lateral film? What can I see? Well, I can see a lot with a lateral film as well. Specifically, the heart structures become very apparent in a lateral film. I can see the aorta as well. I might be able to see valvular pathology on a lateral film. Now I can see the lung fields on a lateral film, but in this case, with this positioning, I'm looking through the patient's left lung into their right lung. So even though I see pathology, it may be difficult to tell right versus left. But the lateral is beautiful in telling us front from back. Okay? So when we talk about location, which we will in a little bit, remember, a standard chest film, AP or PA, will show you left versus right, but lateral will show you front versus back. And the combination will show you where you are. So let's talk about how to read a chest x-ray now. There's a very stepwise approach you can take. I'm going to suggest one to you guys today. You don't have to use the stepwise approach, but I think something similar, if not, this is very important to get used to. You need to get used to reading your film the same all the time, and that way it will become commonplace and it'll become second nature, and you won't make a mistake by missing one of the important things that you may have to look at in a chest x-ray. The most common mistakes are when people miss things that are not what they're looking for. So if you get a chest x-ray and you happen to be looking for a pulmonary pathology, which is quite common, maybe you didn't see the bony pathology that was outside of the chest film. Okay, so they had a humeral fracture, proximal humeral fracture, or something else. Okay, hopefully you would have known that, right? But whatever it might be, it's not just about the lungs. It's not just about the lungs. So first step number one, first and foremost with anything at all, please look at the name and the date. Is this a film that was done today like you ordered it, or are you looking at a film from 3 years ago? This is especially important with electronic medical records now because sometimes you can pull up a film from 3 years ago, which is very useful, especially when you want to do a comparison, but is very bad if you don't pay attention and you're looking at 2 years ago thinking it's today. So date, super important. Patient name, always important. Used to be a problem before EMR where someone could put the wrong patient stuff in the wrong chart, and if you didn't pay attention, you thought there was something wrong with them where there wasn't, or vice versa. Even with EMR, there can be things that are attached improperly to the wrong chart, and this can happen. Make sure it is the patient that you wish to be looking at. That's important. See if you're looking at an AP or a PA film. This is important, and I'm going to explain in a minute what the difference is between the two of them. And the reason why is that structures appear a little differently. And you can see just looking at this here, and we're going to take a look here on the light board. So let's bring these guys up on the light board and look at them comparatively, a PA view and an AP view. Now a PA view gives us kind of a better look. The structures are more in line with their actual size. We can get better inspiration because a PA, the patient should be standing up. It also means that not everyone can have a PA, right? So if somebody is in bed and they can't get up, it has to be a portable chest. That's an AP. The heart size is more realistic in PA. It's larger in AP than it really is for the person. And sometimes when standard AP they're laying down, you'll see that their abdominal contents will shift upward just from gravity, and harder to get a full inspiration and a little different look. So just have an idea of what you're looking at, PA or AP, and it just helps you determine what's going on. So how is an AP done? An AP anterior, posterior, and that's referring to the camera to the film. So the camera is shooting from the anterior to the posterior of the patient, and the film is behind the patient, in this case, in their back. So here's the camera. Camera's shooting down through the person. Here's the film, and we'll go back. Now, nowadays, a lot of things are digital film. It's not actual film, but still, it still gets exposed in a similar manner. This is why the heart size is a little bigger. Your heart's a little anterior, correct? So you think if I had even a light and I shone a light on something and it's a little bit off where the film is, there's going to be this enlargement that occurs, correct? So again, as the patient lays down in an AP view, you may see the abdominal contents shift upward, right, because they're not standing up, and that shortens this a little. Harder to get a full inspiration. Heart size is a little bigger, and these are just some things that you have to consider when you're looking at an AP versus a PA. So remember that a portable film is an AP, correct, because the film is put behind the patient's back, just like you see in this picture, and the camera is going to be in front of the patient, and so the camera would be shooting through the penguin into the film, correct? So portables in AP, they're not laying down, but they still are kind of crunched over. It's hard for them to sit up straight, especially when they're not feeling well. So these films can be difficult. Can be difficult to read sometimes. And remember, we're going to talk about seeing structures and how you deal with a chest film. Remember, one of the things in the steps that we're going to be going through here is, how do you make sure that this film is okay? Do I need to repeat this? Because maybe I can't see what I need to see. And this is some of the situations where you may have that. The person's hunched over, they're rotated, and we'll talk about those as we go forward. A PA chest now, and by the way, the standard film that you would like to get, your order that you would give if you had your way. Okay, you really want to see the most you can see on a chest film, you order a PA and lateral. PA and lateral gives you the best frontal film, and then the lateral helps you confirm. We'll talk about that later. Now, PA and lateral is not always realistic. Again, in a patient who's in the ICU, intubated, and cannot exactly go stand for a PA film. In a PA film, the film itself is in front of the patient. Okay, so here's the film here, and the camera is back here, and the camera is shooting through the patient this way, but the film is right close to all those structures. So that's why you get a better heart size and what have you. Okay. So the heart's right up against that film because the anterior port of the body is right up against the film. So a little better view if we can get that together. Now, step 2, we're going to make sure that we're looking at the film properly. Now, with the digital world, this is much less of an issue, although somebody could still upload it improperly into your EMR or whatever your digital viewer you're looking with. But when we talk about real films that we throw on a light board, this is super important. Okay? So you don't want to have it backwards. Does the patient have dextrocardia, or are you looking at the wrong side of the film? I promise you're probably looking at the wrong side of the film. Dextrocardia is super rare, right? Sometimes you'll see on the top of a film, and I'll show you when we get to some other ones, you'll see like a little L up here. And those are also good reminders of, do you have the film on the light board right? The other way to do it, if you're talking about a real film somewhere down here will have the patient's name, and it'll have a name plate in the picture. If the name is backwards, you are backwards, okay? So look at the name, and mostly orient your 2 main structures, which are what? The heart should be like this, correct? We know this is the way our heart is supposed to lie. Look for the gastric air bubble, all right? The stomach is on the left side of your body, and most of your heart is towards the left side of your body. This is the patient's left. This is appropriate orientation. If you see this, the gastric air bubble's on this side, the heart's on this side, your x-ray is flipped backwards. So just something to think about. You always have to make sure. Again, there's nothing worse than reading a bad film and coming up with a bad diagnosis or treatment plan. Step 3 is to check your exposure. So in this case, if you have bad exposure, this is another situation where you might want to ask to have your film redone. I'm not happy with this view. Please redo this chest x-ray. So you can have underexposed or overexposed. Okay. So if we're overexposed, we get this dark look here, and it's hard for us to tell what's going on. If we're underexposed, things can look a little white, and it might be confusing. You might think that there's something wrong here because it looks like it's patchy here. That's underexposure. It's not pathology, and we don't want to make that mistake. So look very carefully to see your exposure. Step 4 is to check for rotation. Now, rotation means, did you get a straight front-on picture? If I'm looking at the picture of the patient and they're sideways a little bit, they're rotated, they're not sitting straight up, but they're rotated to the left or right, or maybe they're rotated towards me or away from me with one of my right or left shoulders, it is possible for me to lose something in the area that becomes obscured because of the improper rotation, and that's dangerous, correct? So especially maybe a small lesion, but you might miss it completely. So we check rotation as well. And this is another situation where we might say to our staff, hey, I need you to recheck the film. I've got bad rotation. I need to look at it properly. So how do we check for rotation? Again, let's go ahead and look at our light board, throw some films up here, and just take a look at what we might do to check rotation. Left is bad, right is good. Okay, these 2 films, I mean. Correct? So this is, by the way, what I was talking about before. See, there's an R here. Sometimes there's an L here. That helps you figure out whether you're right, left, or right, like I said before. So this is bad. This is good. Why is this bad? What do we check? First, we check for our structures to be centered. Your trachea, which is right here in this picture, should be right in the middle of your spinal column, correct? It's not. It's over to the left. That's bad. And then we look at the clavicles. You want the distance to be centered over the center that you found, which is your spine in this case. And you also want them to be even. So see, this guy's a little higher than this guy. So that's not good. In this case, we see the trachea is right in line with the cervical spine and that the clavicles are equal distant from either side of the trachea. So that's important. Step 5, we're going to make sure the x-ray was taken with full inspiration. And again, we mentioned before why an AP film or even definitely a portable film could have poor inspiration, couldn't we? Little old lady, she's got kyphosis from bad osteoporosis. She's already hunched over. She's sitting in a bed at a 30-degree angle with a venti mask on because she's here for pneumonia, and you're asking her in that bed to take a deep breath. It's not going to happen. Not going to happen. So I'm not saying you have to throw away a film if there's not 10 posterior and 6 anterior ribs, because sometimes you also have to look at your patient and realize that that just may not be possible, but you are going to try your best in order to see everything possible. You're going to try your best to see this in your film. And if you have a patient, especially one who should be well able to do this for you, and it is not present, you need to repeat the film. So you've got a person who's doing that PA for you. They can stand up. They can take a deep breath. You want 10 back and 6 front, or repeat the film. So again, let's take a look at our light box and just look at a bad one and a good one, so to speak. Okay. So in this case, the one on the left, this is the same person, and one has a poor inspiratory effort and the other one has a good inspiratory effort. And when you compare them, it's easy to see that the one on the left is not, doesn't have good inspiration as opposed to the right. But that's not what you're going to see. In reality, the person's just going to bring you this x-ray. So how do you know it's bad? So you check 6 anterior ribs. The anterior ribs are these guys in the front. Right? It's a circle. So the ones that are kind of upward towards the center, that's your anteriors, right? 1, 2, 3, 4, 5, maybe 6. So I maybe get 6. But my posteriors are when they come around. It's the same ribs, right? But see how they come around the back? That's posterior. So I have 1, 2, 3, 4, 5. I only have 6 posterior ribs. I don't have a good inspiration. On this side, if I look at my anteriors, I got 1, 2, 3, 4, 5, 6, 7, 8, 9. It's more than 6. I'm good. I'm more than 6 here, right? And my posteriors, I have 1, 2, 3, 4, 5, 6, 7, 8, 9. So not quite 10 in my back. But this is showing that you have very close to optimal inspiration on this chest film. So look for that. Try to get the best inspiration you can. And you'll also get better structural look, but also more importantly, if you don't have that good inspiration, there may be some pathology, especially in the lower lobes, that you might miss because you can't see it. Step 6, you've got to look outside the box, correct? This is probably the thing people make a mistake quite often, most likely, correct? So you're looking at your film, you got it for X reason, it was not because they had a broken clavicle like this picture. Hopefully you knew they had a broken clavicle, right? but it probably won't be so obvious. So in other words, you got a chest x-ray for a pulmonary pathology, and there is an incidental finding of an extrapulmonary pathology that you missed. Therefore, get used to the fact that when you review your chest film, after you look at the things that you are worried about, you should go back and look at these structures, or as I have it in my cascade of steps, I put this first so I know I don't forget it, because I know I'm not going to forget to look at the lungs in a chest x-ray. But I want to make sure I don't forget to look at extra structures. So look at soft tissue first for deformity. Soft tissue, again, is everything outside. It's the musculature. It's whatever, okay? Interstitial spaces. In this case, this person has some soft tissue swelling here, and the reason why is because of the broken clavicle, but they have soft tissue swelling. So I don't want to miss that on my x-ray. Look at all the soft tissue as well. Step 7 now, look at your bones, joints, okay? Looking for acute fractures like that clavicle, okay? Osteoporosis, old fractures, metastatic lesions, whatever it is. Look at all the bones and joints that are on your film in front of you now. So this one is a little harder to figure out. There's a lot of stuff in this chest x-ray that could be missed if you are reading kind of quickly. Now, how do you check a bone? That's a good question. How do I check a bone? Well, you can just look, and this looks good to me, right? This looks normal. But if I really want to do it right, in order to check my bones, I need to follow the cortex and make sure that I'm intact. Okay? So if I look at this, on the outside of the bone, that line, I want to look and just make sure it's a straight line. So if I'm looking down here and I do that with my ribs, I say that's a nice straight line. That's that's not a straight line. Look at that. There's a little piece broken off. Oh. So remember, look at all your bones. You're saying, is there a straight line here? If it's a fracture like the picture I just showed you with the clavicle, you don't even need an x-ray to figure that out, right? You're not going to miss that. What you have to be careful of is that you don't miss this type of fracture, this small little fracture here. And the way you do it is you follow the line, follow the line, follow the line. Just make sure you don't see a disruption in the outside of the bone. Now in this case, there is a small rib fracture. There's also a pneumothorax. If you guys want to look here, you see this faint line here, and it's darker here. This is the lung. This is air. And this is a pneumothorax caused by this rib fracture. This patient also has subcutaneous emphysema. So we asked in step 6 that's one of the things you look for in the x-ray. It's also something that's a physical exam finding that's pretty impressive. And you see here, because of the pneumothorax, some of the air has escaped up into the upper area, into the interstitial tissue, and caused subcu emphysema. You see the dark in here? That's air trapped inside the tissue. If you were to touch this person here and push, it would sound like Rice Krispies, all a little popping going on. It's very interesting when you see it in person. So this film is a good example of, again, how we need to be very careful and how we look at a film and not miss something that may not be overtly obvious, especially something like a small rib fracture like there is here. Step 8, we're going to look for the diaphragm specifically for a few different things. Position and shape is important with the diaphragm. In COPD, we mentioned the fact that they'll have flattened diaphragms because they have this overinflation, for example. So diaphragmatic changes can represent different things. One of the things we most importantly don't want to miss here is an example like there is in this picture. So the white arrow, this is the diaphragm. Okay, this is the diaphragm, the white line. And this is the abdomen, and there's a darker area underneath the diaphragm. So what is it that causes things to look darker? Because it itself is not dense at all, it's air. This patient has free air in their abdomen. So you're looking at this chest film because the patient came in with nondescript, let's say epigastric pain, or maybe they even described it as pleuritic chest pain. Who knows? Patients present different ways, and you find that they have free air. I may have a perforated viscus. I have an intra-abdominal pathology. So this is how on your chest film you should be aware that you might see something that is not intrathoracic. So looking for free air under our diaphragm is a way we can find an abdominal pathology on a chest film. Step 9, I want you to look at the hilar and mediastinal areas for a few different things. Size and shape of the aorta is extremely important. Presence of hilar pathology, hilar lymphadenopathy, etc., prominence of hilar vessels, and we'll talk about that. So let's look at a light box again. Just look at a few films a little carefully here, and some of the things you might look at. We're going to look at the center of the chest. So now we're focusing at the center of the chest. Okay, the hilum is this area and this area. This is hilar lymphadenopathy. So here we have hilar lymphadenopathy. That can mean a variety of things. The two things we're going to discuss today related to hilar lymphadenopathy are tuberculosis and sarcoidosis, but there's other things as well, by all means. The other thing we're looking for is the mediastinum in general to make sure that the mediastinum is the proper width. Now, in this case, we have a widened mediastinum. So the mediastinum, the aorta should come up. It should have a knob, possibly. Not everyone has a knob that you can see, and it should come down like this. But instead, it's all over here because this is an aortic aneurysm. This is a thoracic aortic aneurysm, and we can see the widened mediastinum that can occur in a thoracic aortic aneurysm. Okay. We can also see mediastinal changes in pericardial tamponade and gross effusion, things like that, where we'll see the mediastinum widen as well. 10, we're going to look at the size of the heart. Okay, and we can look for calcified valves or enlarged atria. That's fine, and you may see those. But single most important thing straight off the bat is heart size. Okay, so number one, heart size. So let's throw these up on a light box. Let's look at these films together and look at what should be and what might be a problem. Your heart should be half the width of your chest cavity. So on this left picture you see, and I'm sure your film won't have the A and B arrows. Wouldn't that be nice, right? So we see that they're equidistant in this case. The half of this person's chest cavity is the same distance as their heart in width. That is normal. Greater than this would be an enlarged heart, for example, this person. This is much greater than half. It's probably 2/3, correct? So this is cardiomegaly. You may see calcified valves. You may see mechanical heart valves. You'll definitely see those, correct? And like I said before, you may see enlargement of other structures. So this person has cardiomegaly. They do have a little bit of right atrial enlargement. You see that bowing that's out here. And they probably have a little right ventricular enlargement as well. Step 11, check your costophrenic angles for fluid, pleural scarring, blunting. You're just checking them. That's what I want you to know. You're checking your CP angles. Check your CP angles. So in this case, the person has a pleural effusion and they're blunted. What is your costophrenic angle? It's this angle right here. On the sides, as the diaphragm comes down, there should be this really sharp angle at the end of that. So here's your diaphragm. That's a gastric bubble right there. Here's your diaphragm. And you've got this really sharp edge, almost like a point that comes at where the diaphragm meets. And on the other side, you should have the same thing, but instead, you've got fluid sitting here above the diaphragm. Here's the diaphragm. Here's the fluid under the lung, in this case because it's a pleural effusion. So blunting of costophrenic angles or changes in costophrenic angles can give you an idea whether it be pleural effusion, etc., or even in pneumonia. Sometimes we see this as well if it's a lower lobe pneumonia. Step 12, now's where we're going to get to the lungs. Now's when we're going to get to the lungs, which is pretty much the primary reason why people get a chest x-ray, right? The primary reason is pulmonary pathology. But what are we checking for? A whole bunch of stuff. And we'll go through that a little more as we go through this lecture and exactly what are you looking for. And I will show you in each of the different pathological situations how and what you look for in the lungs. So the rest of this lecture actually will be talking about what do we do to check the lungs. The other stuff, I just want you to understand you should have that systematic approach in your mind, that you make sure that you do not make any of the mistakes I spoke about, whether it's reading a film that is not properly exposed or with bad inspiratory effort, or whether it is missing something like a bony problem because you weren't looking, you were only looking at the lungs. Be careful. Be careful. Last but not least, if you have a lateral film, then we can look at the lateral film. And the lateral film is going to help us confirm positions, locations. It might help us with AP diameter and such things as COPD that we talked about. It gives us a little better feel of looking at the vertebral bodies here. So we need to have a little more bony attention to the vertebral bodies here than we would in a regular film, although you have to look at vertebral bodies in both. Remember, you look at all bony structures. And then the last but not least is the posterior costophrenic angle. So if you look here, and unfortunately it's kind of a little cut off here, but here is your diaphragm again. And so there's another costophrenic angle right here. And it should be, again, really, really sharp. If this is blunted or there's a little bit of fluid in there, this might represent a very, very small posterior and lower lobe, either infiltrate or pneumonia, that you may not be able to see in the PA or AP view. And this is specifically important when something is retrocardiac. So if something is back here, and this is true of masses or other lesions, if something's right behind the heart, whether it's down here or even here, if you looked on a regular film, the heart's occluding your ability to see it. So retrocardiac inspection is very important in the lateral film to make sure you don't miss something that's there. So lateral chest again, patient stands next to the film, the x-ray is shot through them in order to see the film. So let's look at our films up on our light boards. This is the way you'd like to compare. If you order a PA and lateral, you put them up next to each other so that you can use them in unison in order again to locate what's going on. And we're going to talk about that as we go further in this lecture, about how do you use your lateral to specifically identify lesions that you couldn't see on AP or PA, or clarify location in something that isn't obvious on AP or PA. Another way to think of this, if you guys like these type of mnemonics, A, B, C, D, E, F, airway, bones, cardiac, diaphragm, extras, and fields. Of course, you have to fill in all the extras that I talked about. So make sure you get my 13 steps when you do a film. Again, the lateral is optional. The 12 steps you should do. Whether you use my order or another order, those 12 things must be checked every time that you check a chest x-ray, or you risk missing something one way or another. Another pearl, blind spots. I already talked about behind the heart. Make sure we look at behind the heart, as I mentioned in a lateral film. That will not show up all the time, and very often will not show up at all in an AP or a PA. The apices as well, so look to the tops. Make sure you look at all of your lung fields, of course. We'll talk about pneumothorax as we go through here. Costophrenic angles we mentioned. Chest wall as well. In other words, following the outside of the chest wall is a good way to pick up things like the small pneumothoraxes or pneumothoraces, and we will go through that later in the lecture. Rib lesions are an example. We already went through that one rib lesion that was a small fracture, where lytic lesions can show up that way too. And of course, shoulders. As I mentioned before, and what I told you before, is do everything, not just shoulders, everything that is in that picture. If you can see it, you have to check it. That's a good way of thinking about it. If you can see it on the picture that's in front of you, you should check it. Old films can be very valuable in comparison, especially if we're talking about chronic things or comparing things as far as what's the difference in the last 6 months and how it may have grown or changed. Do I think this is acute or chronic? Look at the old films. Maybe it's been there for 12 years and you're trying to treat it as something that happened yesterday. Consider differential diagnoses, of course, as you look at your film. That will be based on both your history, your physical exam findings, and then the film can help to narrow your differential diagnosis. But remember, a film itself will never give you everything you need. You have to correlate it not only with history, but also with physical exam and all of your findings. Labs or x-rays or radiology are there to help you clarify. They are not there to diagnose, or in other words, you don't want to just order x-rays on everybody, CAT scans on everybody. Think before you do. Some pitfalls just want to share with you that happen to a lot of people. We're looking at this film, and there is an underlying pathology, and let's just look past that today right now because you're not there yet. Again, here's another good example of what I was telling you. You might have an L or an R, but what are these little nodules? There's one here, there's one here. They're very circumscribed. What's that? And did a child scribble on the person's chest? What happened here? Right? So this is sternal wires after open heart surgery, and these are the electrodes for the telemetry monitor that the patient is on. So, there are those foam stickers, and on top they've got the metal button. Well, the metal button is radio opaque. In other words, it shows up on the x-ray. So be careful. Don't be fooled by that, trying to figure out what kind of strange lesion that is. It is the electrodes. Same thing here. We have to be careful with female patients. Most of the time, it's very easy to see that there are two breasts, and they're right there. These are more prominent than some for reasons. This is a little more prominent than normal breast tissue would be, but I chose it just to show you how prominent normal breast tissue can look. But if someone's especially rotated, what have you, you might see a shadow of a breast and think it's something. Remember that breasts are usually dense enough to give a little bit of extra radio opacity, and they may show up and often show up on x-ray, so don't be fooled. And this is just an example of what breast implants look like on chest x-ray. They're hard to miss as well, but this is not a big round mass. Obviously, it is a breast implant. So be careful of those simple things. Let's go a little more further into how we might, again, evaluate our chest x-ray. Now, for every one of the x-rays we're going to do going forward, I am not going to go through the 12 steps, or it would take us 6 hours to do this, correct? I'm just going to be focusing on what pathology I want to show you in that film and show you how that might present. Remember that in reality, however, you are going to, on every film that you look at, check everything. So, a few things. What are some typical densities that we may see, and what do they mean? There's 4 patterns that are standard, or we think of being common. Consolidation is something that fills the alveoli with fluid, pus, blood, etc. Okay, consolidation. So pneumonia, one of the most common consolidations. Okay. They're diffuse, multifocal, ill-defined opacities, and often they may be focal to one geographic location. So I can have a consolidation in my right upper lobe, my right middle lobe, my right lower lobe, etc. Okay? Interstitial means that the tissue itself of the lung. Okay, so in consolidation, something is inside the alveoli, not the tissue itself. But an interstitial density is one where the actual lung parenchyma has now been affected. Okay? Nodules or masses can occupy a space or lesion within the parenchyma, and atelectasis we're going to talk about later in this series. So let's just take a look at what things might look like, what they might look like. A consolidation, again, maybe this is a right upper lobe consolidation right here. Okay, the bottom of the right upper lobe might have some pneumonia or something. Consolidations can be bigger like this. Consolidations can even be small. And in the very beginning of pneumonia, you can have something called tree and bud, where you actually see the tiny bronchus and the alveoli as they're filled with whatever it is. For example, pneumonia, maybe pus or other things. Interstitial markings tend to be less dense as the consolidation, and you may see more of these linear type markings as well. Nodules tend to be very well circumscribed, and masses can be anything from circumscribed lesions to very irregular lesions depending on where they are. Another common sign I think you should be familiar with is what's called an air bronchogram sign. So I already showed you how you can see not only the trachea, but especially the left and right mainstem bronchus on a chest x-ray by that faint appearance of a little bit darker, correct, where that air might be. Well, if those bronchus become inflamed and enlarged, if you will, then you can see sometimes that become more prevalent because the surrounding consolidation or the surrounding inflammation becomes more radiodense or radio-opaque, and therefore it kind of accentuates that inside dead space or air pocket, and it looks a little bit more prominent. So again, let's throw that up on our film here, on our light box, and we'll look at what are air bronchograms in this case. So normally you can see the trachea and the bronchus, but do you see how much better defined they are on the background of all the local inflammation that's occurring here in this picture? Same thing here. Here you can see the bronchogram as well. So there's the trachea and across. So just look for that and understand that that means that maybe there's some local inflammation. Clinically, obviously, correlate that. Silhouette sign. Silhouette sign means that there is something that is occluding your ability to see a differentiation between two structures. So this is maybe a good example here would be this film. So here we have a right middle lobe infiltrate and pneumonia. Okay, so it's the right middle lobe here. However, there is a right heart border underneath here. It exists, correct? However, you cannot see the right heart border because the infiltrate is overlying it, and therefore the silhouette sign is the absence of the right heart border due to the infiltrate with this right middle lobe pneumonia. Let's talk about localizing lesions, infiltrates, etc. Okay, how do we find out where exactly it is in the lung? I just told you that was a right middle lobe pneumonia. How do I know that? How do I know that? So this is basic anatomy, guys, but let's relate to how that anatomy might look on a chest x-ray. How do these look on a chest x-ray? So we're looking at a PA or an AP. The right upper lobe is as it is on the left here, the right middle lobe, and then you can see the right lower lobe. The biggest problem here is not differentiating right upper lobe because there's nothing else up there, correct? So the very bottom of the right upper lobe and the top of the right lower lobe, they can kind of cross over. But most pathologies are dependent and end up starting from the bottom up. Okay? In the case of a lung mass, it might get confusing in the right lower lobe, upper part, and the lower part of the right upper lobe. But for other pathologies, not so much. The right middle lobe and right lower lobe are very hard to differentiate sometimes in a AP or PA, because if you look, they occupy the same space. The right lower lobe takes up all of this. Well, then that's behind this, isn't it? It's on the bottom of this part, and it's behind the other part. So, wow. So if I have something sitting right about here, I don't know what it is off a PA or an AP, and that's something we'll use the lateral for. So what do we use the lateral for? Here you go. If you look on the lateral now it becomes very obvious who's who. Right upper lobe, but now the right middle lobe is this wedge in the front. The lower lobe is all back here. So that will help. Now, in the left lung, it's a little easier. There's only 2 lobes, correct? There's only 2 lobes. But since they cross over each other, this again can be very difficult. Left upper lobe, left lower lobe. Left upper lobe can take up most of the chest field, and therefore lateral films become very important in differentiating the difference between something that could be here and something that could be here. And this is also where, again, I talked before about the lateral being very good at picking up very small infiltrates in the left lower lobe or effusions that are back here, because you can't see them looking at the front because the diaphragm is in the way. So where's this lesion? Where's this lesion? You look at this chest film, you say, okay, I've got a lesion, it's on the right side. It could be in the right middle lobe, it could be in the right lower lobe. I don't know where it is. Okay, so we'll throw that up on the light board. Let's take a look at our PA and lateral and see if we can determine. So here we see that this lesion in the front we couldn't tell, but when we look at the lateral, we realize that this is actually a lower lobe lesion. It's a lower lobe lesion. Because remember, this here is a fissure, okay? And here is the right middle lobe. Now, if you looked at it again, and let's say it was a right middle lobe lesion, although it might be difficult actually to see this with the heart on the right side, then it would be here, correct? So you can take your film from the other side if you need. If you're worried about right pathology, that way you don't have to worry about the heart occluding it. But just for the sake of explanation here, you see now I know this is a right middle lobe as opposed to a right lower lobe, and again I couldn't tell by looking at the frontal projection. Let's talk about how we recognize disease, or how do we determine different pathologies. This can get very complicated, and none of us are going to be radiologists. So we're going to start with the most basic disease I expect you guys to come across, and make sure that you know how to recognize that. Let's talk about atelectasis, pneumonia, and effusions, all of which you guys will see on a regular basis. And they can be kind of tricky to figure out which is which. So let's talk about that. When you look at atelectasis versus pneumonia in particular, I think one of the things that can help us differentiate more than anything is loss of volume. And that only occurs in large atelectasis. So the most common atelectasis you'll see will be small plate atelectasis that's due to a post-surgical situation, or somebody's been in bed too long and they just haven't taken those deep breaths, and small parts of their lung have atelectasis. Now, those will not have volume loss, but large atelectasis will have volume loss, and that will be a great factor and key in determining the difference between a pneumonia and an atelectasis as well. So what is atelectasis? Atelectasis is when your lung tissue actually gets stuck together, because that part of the lung, usually the lower parts, but not always, can be upper just as much, depending on what the pathology is, like mucus plugs, etc. But that area of the lung is not being expanded as much as it should be, or ventilated, depending on what we're talking about, and therefore everything gets stuck together. So in this case, volume loss is a key to atelectasis and large atelectasis. There's no volume loss in pneumonia. There may be collapsed area of lung in atelectasis. Absolutely, that is what it is by definition. Depending on how big the area is, depends on whether you truly have volume loss. In pneumonia, there's no change in lung volume. There's no collapse, but there are focal areas of consolidation. Atelectasis is not due to infection. Obviously, pneumonia is. And what causes atelectasis? A lot of things, but mostly anything that causes hypoventilation of that area of the lung, or decreased expansion of that area of the lung. So commonly it may occur, like I said, in the lower lobes in somebody who is not breathing very well, so to speak, if they've had a pathology, or maybe they're just sitting in bed taking those shallow breaths and they're just not expanding that part of their lung. Or maybe, especially if we talk about upper lobe pathology, someone has a mucus plug and that area of the lung is no longer expanding, let's say on the ventilator, or maybe even by their own accord, and therefore it becomes stuck to itself. The difference between collapsed area of lung in atelectasis and a pneumothorax is that atelectasis occurs because you didn't ventilate it well enough and it is stuck together. But a pneumothorax is literally you have opened the lung up. It's a popped lung, correct? And that is collapsed in a different manner, and we'll show that later. So let's look at this. Is this atelectasis or pneumonia? There's two keys here that make this atelectasis. The first thing is, without a doubt, loss of lung volume, and this we see by the elevation of the right hemidiaphragm. So remember, we talked about diaphragm as part of something we were going to look at in chest x-rays, and this is another thing that can be. Flattened diaphragms, maybe COPD. Elevated diaphragms usually mean that there is lung volume loss, and so here we have an elevated diaphragm, and then this area up here in the right upper lobe. The other thing that makes this atelectasis is if this was a pneumonia and the patient was sitting up, it's over time obviously, then the lobe, the lower part of the lobe would be infected too. So this is where the lobe is, but it's actually collapsed upwards. Okay, so in pneumonia you don't have the volume loss, and therefore the lobe doesn't change shape as it pulls everything up. It would stay this way, the diaphragm would be low, and then this consolidation would be more like this. But instead, this area, this whole lobe now is not ventilated, is not open, and is stuck together. The other lobes are brought upward, and so is the diaphragm at the same time. In this case, what is this? Now here we don't necessarily have significant volume loss because this is what's called plate or linear atelectasis. This small area where just a small part of the lung is stuck together. In this case again, what do we have? We still have atelectasis because the hemidiaphragm is significantly elevated, and we see this whole area now is involved. Now in this picture, we have no elevation of the hemidiaphragm. I have a large consolidation in the lower lobe. I've got this nice cloudy appearance. I've got blunting of my costophrenic angle. This is a right lower lobe pneumonia. Here we actually have a little bit of blunting here too, so they may have some pathology on the left as well. How about this one? So now we have a PA and a lateral, so we're in great shape. First of all, is it atelectasis or pneumonia? Well, again, we don't have any volume loss, and if you have a large area like this, then you will have volume loss with atelectasis. No volume loss. And what's interesting here, so we say, oh, is it middle or lower lobe? My lateral confirms that it's middle lobe, correct? You see that nice wedge shape? That's all the infection just in the right middle lobe. But what's interesting is even looking at the PA in this case, I see that I have a very clear costophrenic angle, which also tells me that this is very unlikely to be a right lower lobe pneumonia because, of course, this would be then involved. So this is a right middle lobe even from this, and this confirms a right middle lobe pneumonia. No loss of volume. In this case, I have no loss of volume, correct? No loss in volume. My diaphragms are equal. I've got a nice costophrenic angle in this case, but everything is diffusely infiltrative. And this is what an atypical pneumonia looks like a walking pneumonia in a younger person. Let's move on now to pleural effusion. Pleural effusion. And pleural effusion, remember, is not inside the lung, it's under the lung. So this is fluid that occurs under the lung between the diaphragm and the bottom of the lung. So pleural effusion is a dependent disorder. The fluid will find its way down to the bottom and therefore sit on top of the diaphragm and under the lung. Sometimes it's even caused from below. The diaphragm is fenestrated, and therefore people with congestive heart failure or other disorders where they have a lot of extra abdominal fluid such as ascites may have chronic pleural effusion. And the way a pleural effusion looks here specifically is number one, looking at that blunting of the costophrenic angle. Okay, now again, pneumonia in the lower lobes can cause blunting as well, especially in the very beginning. But in this case specifically, we have loss of our costophrenic angle on the right side, and we have this nice opacity showing pleural effusion fluid. And this is a case of a very severe pleural effusion, and I just wanted to share this with you to make you know that you can even have pleural effusions that take out most of the lung cavity on one side, even much more severe than what I'm showing you here. and making it difficult, obviously, for that patient on that side to breathe because the lung space is being occupied. So here, not only do we have blunting of the costophrenic angle, we have nothing. It's all, we call this a whiteout. The patient has a whiteout in their right lower area, correct? So it's not really the right lower lobe because the lobe is pushed upward and backward by the fluid. This is under the lung. Let's talk about how CHF might look on a chest x-ray. And what type of CHF, right or left? Left, right? So the left is the congestive heart failure that causes pulmonary problems or pulmonary edema. So here's pulmonary edema on a chest x-ray. That's what we're looking for. A few things that we can see on this film. We see that we just have these kind of patchy areas. They're almost fluffy, right? They're almost fluffy. So there's two things in CHF that we look for. The first thing I would like to see in CHF is enlargement or engorgement of my pulmonary vasculature, because it is that central pressure change that really is causing the pulmonary edema, correct? As the fluid backs up from the left heart, goes backwards, it goes into the pulmonary vasculature and causes engorgement, and then later causing increasing pulmonary capillary pressures, forcing fluid into the alveoli, and eventually filling the patient's lungs. So in this case, we have pulmonary vascular engorgement here, and we also see in the periphery, we start to see this patchy look of congestive heart failure. You may start to see loss of costophrenic angle as well as the fluid becomes more prevalent, because it won't be extrapulmonary like a pleural effusion, but remember, the lungs will fill up from the bottom up. So what will happen is that you'll have more fluid here inside the alveoli, and it'll go, as the person progresses and gets worse, it'll go up and up and up. So this will start to become more patchy from the bottom up as we go. These are called curly B lines, the small areas of patchy consolidation that you see with these vascular markings and as the alveoli fill up. The other thing, what's this here? This is a lead for the monitor again. Okay, so be careful of those type of things. That's just a lead for the monitor. Let's talk about COPD. COPD. So I already went through this with you guys on your lecture, right? So we did COPD together. But remember what we talked about, flattened hemidiaphragms. Flattened hemidiaphragms because they are overinflated. In this case, what are we talking about? We're talking about emphysema, correct? This is not chronic bronchitis, this is emphysema. So when we talk about emphysema with COPD, overinflation of the lungs, therefore we have flattened diaphragms being pushed downward by that overinflation. So again, I have great costophrenic angles, but I have the flattening of my diaphragms, and I have the area here that starts to become a little darker as there is more air because they are retainers. So the fields become a little darker. And then on a lateral film, as we mentioned as well, you'll have an increased AP diameter this way, and you'll have the flattening of the diaphragm too. Now again, what are these here? These are the leads, correct? The other thing I want you to look at is this. If you guys look really closely, do you see this little dot right here? See how it's really circular? And there's one here too, and there's one here too, and there's one here too. Now these can occur on anybody's chest x-ray, and are they tiny lesions? Is that the beginning of lung cancer because this is a smoker? And the answer is no. That is literally the cross-section of a blood vessel, a pulmonary vessel, that's looking straight at you. The pulmonary vessel is actually in the direction straight towards the camera, and the camera there is capturing the picture of the cross-section of that blood vessel. So when you see those, remember that can be a normal finding as well on a chest film. This is now chronic bronchitis. Chronic bronchitis. So now we have a similar picture as we would with congestive heart failure, which is sometimes and often associated with chronic bronchitis. But specifically, we have an enlarged heart. This patient may have cor pulmonale as well. And we have this area of inflammation throughout the entire lung field due to the chronic bronchitis. And we can see the inflammation of the bronchus and the bronchioles as it goes out, this kind of diffuse pattern. Let's talk about hilar lymphadenopathy. And again, hilar lymphadenopathy is associated with other pathologies besides sarcoid and TB. But these are two that we're going to go over here. We can't go through them all in this lecture. I do want you to make sure that at some point as you study, you learn all of the potential pathologies of hilar lymphadenopathy. This is a picture on our light board here of hilar lymphadenopathy. So again, the hilar area is where? Hilar area is on either side here, And now we have hilar lymphadenopathy. Okay, so this patchiness, this increased radiographic density that occurs in the hilar area. So now we think, what's going on? What's going on? So how do we tell it is TB or sarcoid? We look at a lot of different findings within the patient. This is sarcoid here on this picture. You see this diffuse area. So this is severe sarcoid. This is end-stage sarcoid. Beginning of sarcoid, things look a lot less reticulated than they do right here. Sarcoid can have cavitary lesions, as can tuberculosis. And in fact, up here, the arrow is pointing to a cavitary lesion, and I'm going to show you a better one in a few moments. So remember, sarcoid is diffuse. Everything except for miliary tuberculosis is focal. So one of the biggest ways you can tell the difference between sarcoid and tuberculosis on a chest film, unless it's miliary tuberculosis, is the nature of it being either diffuse in sarcoid or tuberculosis, other than miliary, being very focal. The other thing, of course, that's going to really guide your diagnosis is going to be your clinical presentation, correct? Clinical presentation is very important, but we're just talking about looking at it in a chest film. Tuberculosis chest x-ray findings. Primary tuberculosis will be middle or lower lobe infiltrates with hilar lymphadenopathy. Reactivation can have nodular opacities, and you can see cavitations and empyema. And miliary is tiny nodules, but it's diffuse. It's everywhere. It's everywhere. So that may be some different findings that you may see. In this case, this is TB here. We have some calcified hilar nodes. So we've got the hilar lymphadenopathy. There's a Ghon complex here, a small lesion. In this case, we have a cavitary lesion. So cavitary lesion means it's a big area that's usually air and fluid filled. And literally, this is the fluid in there. See, the dark is the fluid, and this is a big open cavitary lesion. Let's talk about pneumothorax. Pneumothorax. This is something you could see much more likely than TB, that's for sure. So let's go through pneumothoraces. The most important thing in pneumothoraces is defining, which can be difficult, the differentiation between absence of lung tissue and air and clear lung. This is also a time when, remember we talked about exposure? An overexposed film may easily be too dark, and that means that you could miss this, correct? So make sure your exposure is good. Exposure needs to be good. In this case, we have a pneumothorax. How do we know we have a pneumothorax? Well, when we looked at our normal lung film, one of the things we needed to see is we needed to see something, correct? So clear lung fields are not empty lung fields on a chest x-ray. The same way, when you listen to somebody's lungs, clear lung sounds are not absent lung sounds. The adventitious sounds that you hear as somebody takes a breath and you can hear the air going in and hear the air going out is extremely important clinically to differentiate between I don't hear anything. And much like that on a chest x-ray, it's extremely important to be able to tell the difference between there is no lung there and it's air and there's normal lung tissue. So we see on the left side here is normal, okay? So this left side is normal. You see all these normal markings. This is a very normal look to a lung. You'd expect this. There's nothing wrong here. But what's wrong here is that there's nothing here. This is this dark appearance of air, and this is the lung collapsed after a pneumothorax. Okay, this is the lung collapsed after pneumothorax. So this is a pretty obvious one. Now the other thing you look for in pneumothorax, and we're not quite there yet on this one, but we're close, you always want to rule out tension. The trachea here is still midline, the cardiac structures and the mediastinum remain midline. This patient does not yet have tension pneumothorax, but this is a big pneumo and it won't take long to start pushing this way. And once we start to see these central structures shift, then we know that we have tension. Hopefully we don't get there. So let's look at this pneumothorax on the other side of the chest. So again, in this case, the right lung looks normal. This all looks normal, and here we see a very large pneumothorax with the black, the dark, and you can see the outside line of the collapsed lung. This is a smaller pneumothorax. So here we see normal pulmonary markings on both sides, but we see a little bit darker here, and you see the very faint line of a small pneumothorax. These are tension pneumothoraces. Now, in this case, it has started to push the central structures across midline. So here on the left, this is all a pneumothorax, okay? And in this case, the cardiac structures have all been pushed this way, and the trachea is beginning to go away from midline. Here again, all pneumothorax, the trachea is here, and everything is pushed across midline. Let's talk a little bit about CAT scan. Okay, let's talk about CAT scan. The differentiation between CAT scan and X-ray, what we might do with it. Again, we're only going to touch on this very briefly. So how does a CAT scanner work? How does a CAT scanner work? The way a CAT scanner works is by using, number one, X-ray technology. Remember that. So when we look at the pictures that the CAT scan is going to get us, they are used using X-ray. Therefore, they are created using density, and that's how my image is formed. It's so important to remember that as we think about when and how we might use these things. A regular X-ray gives you a two-dimensional picture of what you have. And it can't really define on the picture things that are in front or in back of each other. And it can show you a little bit of location change, like we talked about using a lateral film versus a frontal film. But this is a way in which we can literally slice our person up and then find out what's going on. Of course, I mean that figuratively, slicing them up. So when you think of a CAT scan, just think of a spiral ham. Think of a spiral ham. That's the best way to think about this, I think. In the machine, there's the X-ray source. Here's your camera. And here is the detector. So in other words, it's not the film per se, because this is going to computerize, right? Computerize what the image is and create it. But it's almost like the film in the way we did it. This thing is going to spin around, and as it spins, it is taking a picture that is now taken by the computer and translated, and the person, while it's spinning, is going to be moving this way, meaning that I'm going to make the person a spiral ham, correct? And therefore, I am going to look at different levels. So as I do, I get these pictures almost as if we slice them up. Almost as if we slice them up. So here might be, for example, this might be here, this might be here, this picture here might be here, and this is how we get these different sections of CAT scans. That's how it works. CAT scans, there's a lot of reasons and why you use CAT scan. We can't cover that all in this lecture. It will be covered as you go through clinical medicine in each specific area, as will the nuances of tuberculosis and sarcoid and what have you that we didn't cover today, because we're just talking about chest X-ray and a little bit about CT. So yes, definitely for a follow-up, CAT scan is almost never your first scout look at what's going on. It's seldom that you should use this as a scout look. You should have an idea of what you're looking for before you order a CAT scan one way or another. A normal CAT scan has 10 millimeter thick cross sections. A high resolution is only 1 millimeter. So your spiral hamming is a centimeter or 1 millimeter, depending on which one we order. Okay. A spiral is quick. It's quick and fast. And the patient has to hold their breath, it's true. And it can create a much quicker image. Spiral CT can be as good, but it is less available. That's true. And remember, we're talking about contrast. Do you give contrast with a CAT scan or not? There's a lot of different things that decide whether or not you give contrast. Now, first of all, you're giving contrast to accentuate something. If we're talking about IV contrast, we must always remember that can cause renal failure. It causes acute tubular necrosis. Not in everybody, but it can happen. So we have to be careful with patients who have renal insufficiency, and all patients we need to monitor closely after receiving the intravenous dye. We can use it to accentuate vascular areas. We can use it to accentuate intraluminal areas in oral contrast. So there's IV contrast, but we talk about abdominal CAT scans. You might use oral contrast and look at intraluminal things. But most importantly, you're using contrast to accentuate something as far as a structure, either vascularly or structurally, that you cannot get otherwise. Low-dose CT is something we should consider mostly for screening here. So this is a newer thing. The new guidelines state, as it says here for you guys, annual screening for lung cancer with low-dose CAT scan is for anyone 55 to 80 years old who has a 30-pack year smoking history and they currently smoke or they've quit within the past 15 years. So every year they do a low-dose CT. Now it's low-dose because we cannot radiate people on a regular basis, or we do increase their cancer risk. And I do want to tell you just one thing as a side note. Remember when you talk about ordering any radiation, chest x-rays are very low radiation, and they currently smoke or they've quit within the past 15 years. So every year they do a low-dose CT. Now it's low-dose because we cannot radiate people on a regular basis, or we do increase their cancer risk. And I do want to tell you just one thing as a side note. Remember when you talk about ordering any radiation, chest x-rays are very low radiation, and you're probably okay ordering a chest x-ray. A CAT scan is many, 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 many times more radiation than an x-ray. The idea of lifetime radiation exposure should be in your head always. It's very important with children, but it's important for all of us. If you were to add up all the radiation of all the CAT scans, x-rays, etc. you got throughout your life, that is your lifetime radiation exposure. Every single time you order a study, you increase the patient's lifetime radiation exposure. The more their lifetime radiation exposure is increased, the greater the likelihood of having cancers specifically later due to that. In children, this becomes very important. So be very careful. You don't CAT scan children, for example, if you can avoid it, because you do not want to have issues, especially with childhood cancers that can occur with multiple large dose radiation exposures as a small child. So remember, this is not free. You can't just go get a CAT scan because you want to go look. There's a reason. With this in mind, the reason why the CAT scan is low dose as a screening tool is that if we use a regular CAT scan, we would be obviously increasing the person's lifetime radiation exposure significantly. Low-dose CAT scan can be used annually for these patients to look for lung cancer. It's been proven to be advantageous in finding cancer early. Of course, the best thing is that they quit smoking, and if they are already 15 years post-smoking and they've quit, in other words, 15 years ago or more, you stop the screening. So just to give you a quick look, and we're not going to go through interpretation of CAT scan. Most of you won't have to do it, but I just want to have an idea for you of exactly how this works. So the first thing I want you to remember when you're looking at these pictures is that you are looking at the CAT scan as if you're looking from the patient's foot up into them. So that means that this is their left side and this is their right side, right? So you're looking from the foot, from the bottom up. And so this slice, the yellow right here, this slice is this picture. So we see that we have this cavity and a consolidation. Now, as the CAT scanner moves down here, okay, and the patient then moves through the CAT scanner, through the donut, right? The next picture we get is here. And now we see a different part of the consolidation. Okay, they still have a trachea, that's good. Okay, and then if we continue, we go down even farther, we can see how the cavity, the consolidation, how it changes. We also see that we're starting to see some other structures, correct? So right here is just a trachea, but now as we get down a little farther, we start to see the top of the heart, right? The pulmonary artery and ascending aorta, because now we're down here. And you're starting to see the bottom of this lesion, because now we're coming out of it. So this is just an idea of how a CAT scan gives you a picture and how it can be used to identify exactly what's going on. So here, some more pictures of CAT scans, in this case showing cavitary lesions. Okay, a lung abscess on the left, cavitary lesion on the right, and what it might look like. Pulmonary angiogram you should be at least familiar with. It's considered a diagnosis for pulmonary embolism. Okay, so the femoral vein is catheterized, the patient's injected with contrast dye. Remember, it's the same dye that can cause renal issues, but it's important. And then we see what is going on. So this is a normal pulmonary angiogram. As the dye travels through the patient's body and then is pumped through their pulmonary vasculature, then we start to see what their vasculature looks like. So this is normal. And for example, in pulmonary embolism, it might look like this. So we see on the right side a very nice look to our pulmonary vasculature, and on the left side, what in this case is a very large pulmonary embolism, and the fact that we're not having blood flow to that part of our lung. A CT angio, we call, or a pulmonary angiogram with a CAT scan, is used for PE as well. And now we're going to get those slices. We're going to get those slices we talked about. So in this case, just to give you an idea of what it might look like, again, this is what normal looks like. This is normal. You can see all the pulmonary arteries. Again, when you see those little circles, see that little circle, and this little circle, and that little circle, that's when there's a vessel looking, it's being transected in this case by the spiral ham machine, right? So it's being transected, and that's just a transection of a vessel. But here, look, we're missing what we should have, and in this case, you can actually see the emboli sometimes in the actual CAT scan. This is a bilateral, this is not a good situation. So that's just a quick overview of CAT scan, but a little more in-depth view of X-ray. And what I need you to do in the most basic form, just to start looking at interpretation of X-ray. If you become an ER PA or an urgent care PA or a pulmonary PA, you're going to get much more advanced than what I've shown you today. But this is a good start. I hope you've all enjoyed it, and have a great day.